My name is Dr. Edward Evantash. I am an OB/GYN as well as the medical director at Hologic. I recognize the difficulties with keeping up with the latest literature and guidelines that affect our clinical practice. Our goal at Hologic is to identify relevant articles and provide a concise breakdown of the clinical highlights and conclusions. Every physician who treats women with menstruation problems will use some term to describe abnormal uterine bleeding, such as dysfunctional bleeding, menorrhagia, metrorrhagia, menometrorrhagia, dysfunctional uterine bleeding, hypermenorrhea, etc. A standardization for the nomenclature has recently occurred for abnormal uterine bleeding in non-pregnant women. And this is the FIGO classification, which has now been adopted by all the major societies, including the American College of Obstetricians and Gynecologists, ACOG. The main reason behind standardizing the nomenclature is to further emphasize the importance for understanding the real reason for a patient having problematic menstruation. In two recent publications, this classification system is further described. One paper is from the Gray Journal, written by Malcolm Monroe from the United States, and Ian Fraser from Australia, and Hilary Critchley from the United Kingdom. The other article is a practice bulletin from July 2012 released by ACOG. In the Gray Journal article, the classification system is described and essentially divided into two sections: the structural components and the non-structural components. And the structural components are described using the acronym PALM, P-A-L-M. P is for polyp, A is for adenomyosis, L is for abnormal uterine bleeding due to leiomyoma, which is a fibroid, submucosal or otherwise. M is for malignancy or hyperplasia, the endometrial cancer precursor. The non-structural underlying reasons for abnormal uterine bleeding use the acronym COEIN, C-O-E-I-N, and include C being coagulopathy, either due to an underlying disease such as von Willebrand's disease, or induced by the use of anticoagulation medications such as warfarin or heparin. O for ovulatory dysfunction, AUB-O, which we recently discussed in an ACOG practice bulletin. E for endometrial causes, AUB-E implies that there was thorough workup with no underlying abnormalities identified. I for iatrogenic causes. Iatrogenic means that it was induced by either medical intervention or procedure or some other medication that led to the bleeding. And N for nonspecific, usually very rare causes such as an arteriovenous malformation. With the PALM-COEIN nomenclature, the acronym should be listed and followed by a description of the underlying cause. For example, if the patient has bleeding due to anovulation, she has non-cyclic bleeding, that would be described as AUB-O. Now, if the patient has bleeding due to the presence of a uterine fibroid, that would be described as AUB-L. Now, for AUB-L, leiomyoma, the pathology may be a type 1, type 2, or type 0 fibroid, and that can also be listed as a subheading to describe the exact location of the fibroid. Both the practice bulletin and the Gray Journal discuss patient workup, most importantly pointing out that a careful and directed history is necessary. Laboratory studies should initially include a complete blood count and a pregnancy test, HCG, to exclude the possibility of pregnancy. Thyroid testing, by obtaining a thyroid-stimulating hormone level, is an easy and inexpensive way to exclude thyroid dysfunction, which is a common cause of abnormal uterine bleeding. Now, tests that may be done at the physician's discretion include a PT, PTT, and bleeding time if the patient has evidence of AUBC, coagulopathy, as determined by her history. And there's information in the practice bulletin, including a checklist, which can determine if AUBC may actually be her diagnosis. Follicle-stimulating hormone may indicate her menopause status. Prolactin can exclude the possibility of a pituitary disorder, and testosterone levels may be helpful for supporting a diagnosis of polycystic ovarian disease. In the practice bulletin, substantial evidence exists to indicate that sonohysterography is superior to transvaginal ultrasound to detect intracavitary abnormalities such as polyps and submucosal fibroids. Women 45 years of age or older are at risk for hyperplasia and should undergo an endometrial biopsy based on level C recommendations. It's very important that all physicians adopt this new nomenclature, as you can anticipate that most of the current published research on abnormal uterine bleeding will incorporate this classification system. It's also beneficial to incorporate this classification system into everyday practice. Good and accurate record keeping and charting of patients who have abnormal uterine bleeding will assist in the transition of using this new nomenclature. The PALM-COEIN classification system furthers the need for directed diagnosis that identifies the underlying abnormalities responsible for your patient's abnormal uterine bleeding. As a physician, you'll feel more confident in your treatment decision, and this will allow for more targeted therapy and ultimately better outcomes.